I'm Alicia. This is for Issues in Public Health, Community and Global Health 210, and this is my analysis of the implementation of the CDC's colorectal cancer control program among an underserved population in Chicago. In this presentation, I will be looking at two studies, one of which is a compilation of 5 case studies that was used for the development of the CDC's colorectal cancer control program, and an additional case study, which looks at the actual implementation of this program in an underserved community in Chicago once it had been developed. Um, the background surrounding colorectal cancer is that it's the second leading cause of cancer death in the United States. It's seen very frequently in both men and women, although men are less likely to get tested. And recommended screenings can detect precancerous polyps, which can be removed surgically and receive other therapies to prevent cancer from even starting. And screenings can also detect early stage colorectal cancer, which decreases mortality and would ultimately reduce the burden of disease that comes from colorectal cancer. At the moment, only around 69% of average risk adults between 50 and 75 are up to date with screenings. The majority of the people that lack screenings are in the lower parts of that age bracket. And as you look at data, you see increasing percentages of people that are up to date with regular screenings once they get older. But it doesn't but there's a gap between the average risk adults and the number of people that are getting tested in those different categories. Some people are less likely to receive screening, which puts them at higher risk. And these groups of people that are less likely to receive screening include men, Hispanic people, American Indian or Native American people, Alaskan Native people, people 50 to 64 years old. So again, the beginning part of that age group that you would traditionally consider eligible for colorectal cancer screening, people that live in rural populations, which can impede access to clinics and to places where you would go and receive these screenings, or where you'd be able to drop off something like a stool sample. If it would be too far to drive, then that's something that could definitely impede access. And then lower income and education levels, or populations with lower income and education levels, the uninsured and the underinsured. Looking at this data, the CDC decided that they were going to implement a program, and they did an implementation study from 2005 to 2009, which led to the current program, of which Chicago is a part. So the CDC program sought to address clinics that serve low-income communities where less than 60% of the recommended population for screening, according to the CDC, which is ages 45 to 75, are up to date. Up to date implies receiving screenings regularly, which can look like a regular colonoscopy or a regular stool test to otherwise determine that you're not at risk for colorectal cancer currently. And it's centered on the idea of evidence-based interventions, which is an existing solution that was used often for cervical cancer and for breast cancer that was then applied to colorectal cancer with varying levels of success for different interventions. But some of these interventions include things like patient navigation, which can include talking to patients about transportation and how they're going to get places, discussion about medical hesitancy, especially among some of these groups. When you're considering groups that are at higher risk for colorectal cancer, you're also looking at groups that are going to be more hesitant to receive medical care, including minority groups, people that are of lower income who would rather not take that time off of work or have to pay to receive medical care. Um, this can also look like patient and provider reminders. Provider assessments is another aspect of evidence-based interventions that proves to be really successful. If you do provider assessments, you can increase screening, according to the CDC, by around 13%. And so this is successful for increasing colorectal cancer screenings in the 2005 to 2009 study. When you look at the 2005 to 2009 study, at the end of it, they came up with this implementation themes and lessons from cross-case analysis, and this was used to inform the Chicago program. And there's 5 headings total of what they took away from that, which can be then transformed into somewhat of a SWOT analysis, where you can look at strengths, weaknesses, potential outcomes, or things that can be gained, and then threats. And so the complexity of colorectal cancer screening means that there's multiple different types of tests available, which can be something that is a strength, because someone may not be comfortable with getting a colonoscopy, especially considering social connotations surrounding homophobia or people who have experienced sexual assault in the past. But the complexity of colorectal cancer screening means that sometimes certain people will be recommended for one type of screening and other people will have to receive a different type of screening, like stool samples as opposed to colonoscopy. And that occasionally people are at different risk factors. And that's something that proved to be really difficult to explain to both patients and to providers when they were trying to provide this care in the 2005 to 2009 study. Of the 5 sites, a couple of them decided to standardize and go with stool samples exclusively, and some of them went with colonoscopies to begin with exclusively, whereas in those that went with stool samples first, you would get a stool sample, and then if your stool sample came back positive, then you would have to go get a colonoscopy, as opposed to just getting a colonoscopy straight from the get-go and standardizing it for everyone to get one. In the 2005 to 2009 study, there was a lot of complexity in assessing different symptoms because this study wanted to test the effectiveness of evidence-based interventions for the increase of screening among asymptomatic patients. So anyone that could have something that was perceived to be a colorectal cancer symptom was not allowed to participate in this study. This could include things like stomach pain, or, well, I mean, not stomach pain, but like severe abdominal pain or certain other qualifications. Like if someone had a hemorrhoid and a small amount of blood appeared in the stool, that would disqualify them, despite the fact that most care providers would then decide that that was probably just a hemorrhoid. And in addition to that, if it was symptomatic of colorectal cancer, these were people that probably should be receiving screening. You also have the ability to integrate into existing systems, which means that a lot of what you're doing for colorectal cancer screening is dependent on what already exists in the infrastructure in place. This program and what they came up with relies very heavily on the collaboration between partners, the CDC and different clinics, and these people that are receiving funding, how they're doing it, community health workers. And so for that reason, you can adapt it to the community, which is a strength. Everyone has different evidence-based interventions that are going to work differently. If you're in a rural area, it's going to be a lot more necessary to go and pick people up driving. If you're in a more urban area, that might not be as necessary, and an evidence-based intervention that could be more effective might be calling people, might be talking to people about the exact procedures that they're going to be undergoing and why they're undergoing it. The evidence-based interventions are seen as a strength of this program because they're proven and developed, and that means that they work. You've seen them work with colorectal cancer, you've seen them work with cervical cancer, you've seen them work with breast cancer. The demonstration of that is a strength in this program. And additionally, you have emergency medical records. Digital emergency or electronic medical records absolutely change the game as far as how you're able to monitor populations and symptoms. And the use of electronic medical records means that you are more easily able to see who has been screened, who hasn't been screened. However, one of the weaknesses of this program, and going into it at the outset, the Chicago program, is that there really was a low screening rate. In order to qualify to be part of the CDC's colorectal cancer control program, you have to have a community where less than 60% of patients are up to date on their colorectal cancer screenings. Colorectal cancer is complex to assess. We've already talked about the fact that different people receive different tests and that symptoms cause exclusion, despite the fact that maybe those people are the people that physicians feel should be receiving those tests and should be receiving more medical attention. Things that you have to gain, though, are things that, like, opportunities that you have include the integration with the existing system. That is something that can make this framework easier to work with and that can increase the success of the intervention. And increasing screening is an opportunity that is the desired objective of this study and of this program implementation. However, threats to this include taboos, medical hesitancy, certain barriers to care, and this thing that was described as the ick factor in the original 2005 to 2009 study, which discusses the fact that colorectal cancer can be uncomfortable for both physicians and patients to talk about, to the point that in initial trials, physicians did not feel very comfortable addressing colorectal cancer and using words directly with patients as far as stool in phone calls or addressing what happens in a colonoscopy and the fact that you have to be placed under anesthesia. Societal taboos such as homophobia and connotations surrounding sexual assault for people that people that have experienced sexual assault, sometimes that can be a barrier and a hesitancy to going under anesthesia and then receiving a colonoscopy because you don't have that control, and you're also receiving something like up your rectum for the purposes of your health, but that's still a lot of trust to be placing in the hands of a care provider. So now, once they had established this framework and they looked at successes, weaknesses, opportunities, and threats through the eyes of this implementation theorems and lessons from their cross-case analysis with the 5 original sites, we get into the epidemiologic data for the Chicago specific program, which took place at the University of Chicago Center for Asian Health Equity and partnered with local federally funded qualified health centers under Heartland Health Centers. And there were 7 community clinics involved in that. People that were eligible for this study were active age-eligible patients, age-eligible meaning between the ages of 45 and 75, who had visited the clinic during pre-implementation or implementation. There were 2 phases of this trial, one occurring between January 2015 and December 2015, which was pre-implementation, which was all about planning and hiring and getting ready for the phase that was January 2016 to September 2017, which was the actual implementation, giving people colorectal cancer screenings and monitoring how those screenings had changed prior to implementation. So then we get to look at key features of implementation that ended up making this so successful, and that became a pinnacle for how they were going about this. For readying the assessments, you had participatory implementation where people would assess their ability to put in these EBIs and increase colorectal cancer screening. This can look at making sure that you have an electronic medical record that can do data reports for population management, that you have staff for care coordinators and a provider champion who is going to work with your patients directly, and also monitor rates of colorectal cancer screening for providers and talk to them about their performance and make sure that they're being held accountable. Then you have these evidence-based intervention implementations that included provider and patient reminders. Provider reminders were manual and they were input when a patient was scheduled to come in that they saw as being at risk for colorectal cancer in this age range. And that was a manual reminder that could only be dismissed once this person had received screening or had been determined not needing to receive screening. Patient reminders for appointments and follow-ups, I believe 140 days after if they'd received a positive test and had not scheduled a colonoscopy come in. Then there were care providers that would call to see if patients would be willing to come back in to get that colonoscopy and make sure that they were following up on their care. And then you have emergency medical records and population management tools, which was really what helped understand how these changes created increased screening within the population as a whole. Players and stakeholders in this include the CDC, as they're the people that have created this colorectal cancer control program. And so what is happening in this study is a direct representation of the CDC. The University of Chicago Center for Asian Health and Equity, who received this funding from the CDC for the purposes of implementing this program under the CDC guidelines. It came from the 2005 to 2009 study. Heartland Health Centers, which was where the care was actually taking place, and then Chicago patients of Heartland Health Centers, because they're the ones that are receiving the impact of care. They're the stakeholders in this situation. The quality of care and the effect of these evidence-based interventions is going to have a direct effect on the health and population of these Chicago patients. So when you're looking at the results, we can look at figure 2, which is the CRC screening statistics in participating clinics before and after implementation. You can take a look and see that you have pre-implementation 3,235 people that are age eligible. You have more people that are age eligible later, but you have a change in the number of people that receive screening, an increase from before. And then you also have from 18% to 37%. You have a decrease in people who are not up to date with their screening at the time of visit from 75.8% to 69.6%. And then the number of individuals who then received an order for the screening and completed it goes up drastically from 2.4% to 23.6%, demonstrating that their education and their outreach, encouraging people to come in and get screened and having completed it, is in fact working. When you're looking at these results, additional summaries include a 19% increase in mail orders and screenings, which is one of those vulnerable populations, a 24% increase in the Hispanic population for screening, and 28.2% in Asian patients. You have a 31.3% increase in screening for uninsured patients, 19.8% increase for Medicare patients. And then you can look at alternatives for future studies. That goes over a couple of the limitations that come with this intervention, which include the fact that these evidence-based interventions were done in conjunction with one another and were not isolated. So you don't really know which ones were the most effective. You only know that they were effective. And for another study, it might be important to separate them into only using one evidence-based intervention to see which one is the most effective, or if there's one that's maybe not as effective that was previously believed to be. The second is that this is what the study refers to as a diverse urban underserved population, which is not representative of other communities which have different needs, which goes back to the conclusions of the study from 2005-2009, which was that the different sites needed to do different things to meet the needs of their patients. Collecting information on diagnostic colonoscopy follow-ups, they really stopped at the screening stage, and did you get your screening? Did you go to get your colonoscopy? They don't really talk about rates of cancer that were caught or rates of cancer that may have been prevented in that way. And so implications from this study include the displays of effectiveness of manual provider reminder systems supplemented with patient reminders and physician assessments, which is where they would compare the number of screening rates from physician to physician in the area, and increased screening in Asian, Hispanic, and uninsured populations, which is the ultimate goal of the CDC's colorectal cancer control program. And overall, in this presentation, I've gone over how this framework was created by the CDC and then its implementation specifically in Chicago underneath the University of Chicago Center for Asian Health and Equity with Heartland Health Centers. And you can demonstrate how these evidence-based interventions were effective in decreasing colorectal cancer, but also some limitations that might mean that this is not applicable to other areas. This really is area-dependent, population-dependent. Thank you so much. I've had a great semester, and I hope that this video uploads and finds you well.